Today we are talking about preventing mother-to-child HIV transmission and caring for infants and children. Give me just 1 minute. I have to reload the other slides.
This conference will now be recorded.
Okay. Give me another slide here. Sorry. Assalamualaikum everyone. We are starting our webinar today and thanks for joining us. First of all, our disclaimer, all views expressed in these webinars are of individual presenters only and do not represent views of any institution. Number two, this is a volunteer project aimed to reduce stigma and increase awareness about HIV disease in Pakistan. No one is hired and paid by any institution to do so. And our group does not affiliate itself with any political, ethnic, or religious denomination. There are some rules during that presentation. All computers other than the host and two co-hosts, which are me and Dr. Rizwan Naeem and Dr. Aziz Somro, will be unmuted and everyone else is on mute. And please write your questions in the right-hand side panel. And please ask questions relevant to today's topic only and keep them brief. Dr. Aziz Somro will handle the questions after all questions coming in the queue have been answered. And please fill out the evaluation forms sent to you after these webinars to help us evaluate the impact of our efforts. So today is webinar number 4. We'll have Dr. Jerome Larkin starting his presentation. So I will just briefly introduce our 3 guest speakers. Dr. Jerome Larkin is an assistant professor of medicine at the Brown University School of Medicine. He is director of inpatient infectious diseases consultation services. Dr. Larkin received his medical degree from Robert Wood Johnson School of Medicine in New Jersey. Completed his residency training at the Bayside Medical Center in Massachusetts and a fellowship in infectious diseases at the Dartmouth Medical Center in New Hampshire. He specializes in internal medicine and infectious diseases. He sees pediatric HIV patients at the Harrisburg Children's Hospital, Rhode Island. And then our second guest speaker at this time is Dr. Sabina Holland. She is assistant professor of medicine at the Brown University. She is the medical director of the Pediatric HIV Clinic and associate program director for the Pediatric Infectious Diseases Fellowship Program. Dr. Holland received her medical degree from Louisiana State University School of Medicine. She completed her pediatric residency at the University of Florida Pediatric Residency Program. She completed a fellowship in pediatric infectious diseases at Brown University, Harrisburg Children's Hospital. Her research interests include improving the transition from pediatric to adult care for HIV adolescents and young adults. I will introduce our third guest speaker, Dr. Susan, at the end of these 2 presentations. And now I am handing this to Dr. Larkin.
So I can just Yes. Okay, so this is Jerry Larkin. I'm going to talk a little bit about the clinical aspects of HIV infection in children, and then Dr. Holland will follow with a discussion more of antiretroviral therapy. And I've actually shared my cell phone right there. I'd be happy to receive calls in the future if clinical questions come up. And there's a lot more information in all these slides than we'll actually be able to touch on in the brief time of our webinar. But I have given Dr. Gilani permission to share the slides with all of you. So first, in case this has not come up in previous webinars, are two really important websites that have a lot of information that could be available to you. One is the aids.info.nih.gov, the guidelines. These are comprehensive guidelines of antiretroviral therapy and the evaluation and treatment of people with HIV put out by the Centers for Disease Control. The second is the AIDSETC.org, and this is a website run by the University of Washington that has a vast amount of information as well as training modules that can be used to educate other healthcare providers as well as patients. So these two websites, you could probably find any question that you have, you could probably find an answer at these two websites. So first, really to touch on briefly is the acute HIV infection, and this is a flu or mono-like syndrome that will look a lot like influenza or mononucleosis that is seen 2 to 6 weeks after exposure. It's really characterized by fever, rash, sore throat, muscle aches, headache, vomiting, diarrhea, and stiff neck. It looks like a lot of different viral infections. However, it might be something that you will see particularly in older children and adolescents as they are seroconverting and as HIV infection is being established. And it may be a good prompt to do testing at the time of presentation as well as anywhere from 2 to 6 weeks afterwards to see if this is a patient who may, in case they have had a significant exposure, may be developing HIV infection. About 50% of people who are subsequently diagnosed, even years later, may recall an illness like this. And one of the things that is relatively characteristic about it is the presence of rash, as opposed to many other viral non-specific illnesses. It's associated with a time of high viremia and low CD4 count, and there's a high risk of secondary transmission from patients like this if they have an appropriate contact with someone else. It actually typically resolves in association with the development of antibody to HIV and is diagnosed by viral load testing in the appropriate clinical scenario, or if a person is HIV seronegative at that time, meaning antibody negative, subsequent testing anywhere from 2 to 6 weeks later. So infections in children, most, at least globally, are via maternal to child transmission. And of course, these are all compounded by decreased access to healthcare services and the fact that most women deliver at home and a general lack of HIV awareness. So the natural history of HIV, you will see a time of high viremia at the point of infection and then low CD4 count. And then as infection is established, the HIV viral load comes under some control in the red curve here, and the CD4 count or the immunologic function experiences a certain rebound. And then the person who is infected enters a period of clinical latency anywhere from 5 to 10 years, during which they may feel well, but then subsequently start to develop symptoms of HIV due to opportunistic infections. This is a time of ongoing CD4 destruction and viral replication and B-cell clonal expansion. In children, you may see nonspecific lymphadenopathy and hepatosplenomegaly. The median time from HIV infection to symptomatic disease in children is really much shorter than it is in adults, and maybe months to 1 to 2 years. A brief view of the CD4 count. With viral load, it is the best predictor of disease progression. Viral load level indications are less clear. Most people would treat a viral load of greater than 100,000 and a CD4 count of less than 200. Current U.S. and WHO guidelines, however, recommend treatment for all people living with HIV, regardless of age, CD4 count, or viral load. A normal CD4 count is anywhere from greater than 500 to over 1,000, and the CD4 percentage is usually greater than 35%. As HIV infection progresses, you start to see CD4 destruction, and that number start to decrease, so that you have moderate immunodysfunction between 200 and 350 CD4 cell counts, and then severe immune dysfunction at less than 200. This is generally true of children over the age of 5 years and adults. However, in younger children, particularly infants, the CD4 count is quite different. So a normal CD4 count in a child is greater than 1,500. Between 1 to 5 years, their CD4 count is greater than 750 to 1,500, and then at greater than 6 years, as with most older children and adults, a normal CD4 count is anywhere from 500 to 1,200. The implication of this is that a CD4 count in a child under the age of 5 years that is ostensibly normal, i.e. in the 900 to 1,000 range, and in particular in children under the age of 12 months, actually denotes relatively severe immune dysfunction. This is represented in this slide, where if you look at the under 12-month column, even a CD4 count of greater than 750 denotes moderate immune dysfunction, and anything less than 750 denotes severe immune dysfunction. That also means that we oftentimes use CD4 percentage in children, particularly under the age of 12 months, to assess immune dysfunction. So HIV infection in infants, it's roughly divided into rapid and slow progressors. Approximately 15 to 20%, maybe as high as 25%, will progress rapidly in the first year of life, whereas 75% or more will have a more slow progression. Children who are infected horizontally, i.e. from needle sticks or later in adolescence, possibly from sexual contact, will act more like adults and be less likely to be rapid progressors. However, mortality before age is very high in the rapid progressors, with a median survival of approximately 11 months. Viral load also increases rapidly in infected infants in the first 2 months of life if they are infected perinatally, and then declines over the next two years. For this reason, all infants under the age of 12 months with confirmed infection should receive both antiretroviral therapy and PCP prophylaxis beginning at 4 to 6 weeks. This is because PCP, or pneumocystis pneumoniae, is the greatest contributor to mortality in this age group. So some of the common clinical presentations of HIV in children include lymphadenopathy, hepatosplenomegaly, PCP pneumonia, particularly in the first year of life, lymphoid interstitial pneumonitis, which actually portends a better prognosis than PCP, esophageal candidiasis, failure to thrive, development delay, encephalopathy, and recurrent bacterial infections. Children are also particularly prone to CMV retinitis, colitis, and pneumonia, parotitis, unexplained fever, and recurrent or persistent diarrhea. So as you can see, it can be a very pleomorphic disease presenting in very, very many different ways. So pneumocystis carinii pneumonia, 50% of AIDS diagnoses in the first year of life are due to this type of pneumonia. It presents with tachypnea, hypoxia, and often normal auscultatory findings. It may have a more insidious presentation with cough, poor feeding, dyspnea, or weight loss. It typically shows a bilateral perihilar interstitial infiltrate with peripheral sparing. Mortality is up to 100% if untreated and 5 to 40% with treatment. And the treatment is usually Bactrim or trimethoprim sulfamethoxazole, usually accompanied with steroids. And in this chest x-ray, you can see the perihilar infiltrate around the, again, relatively generous part of the young child. Lymphoid interstitial pneumonitis tends to present in older patients, older children with a median age at diagnosis of 14 months. It also has an insidious onset with chronic cough or tachypnea, and it's associated with lymphadenopathy, hepatosplenomegaly, and parotid enlargement, and oftentimes with clubbing. It looks like a more reticular nodular infiltrate on chest X-ray, and overall they have a better prognosis. Treatment is supportive, although steroids have been used with exacerbations or with oxygen requirements. And then there are multiple recurrent bacterial infections that children with HIV are susceptible to, in particular strep pneumonia, Haemophilus influenza, Salmonella species, particularly in Africa, sub-Saharan Africa and Southern Asia, invasive Staph aureus and Pseudomonas. One of the hallmarks of HIV disease in children is also wasting, with a persistent weight loss of greater than 10% of baseline, and a downward crossing of more than 2 major lines on the weight per age chart, or less than 5th percentile on weight per height chart on 2 consecutive measurements. Candidal esophagitis is associated with prior antibiotics and prior oral thrush. It presents with drooling, adenoaphasia, retrosternal chest pain, fever, nausea, vomiting, hoarseness, and sometimes GI bleeding. Treatment is fluconazole. Developmental delay and encephalopathy are also important hallmarks of HIV infection in children. It's usually manifested by failure to attain or loss of milestones, impaired brain growth or atrophy on imaging, and microcephaly. You may see gait impairments, motor deficits, paresis, spasticity, seizures, and calcification of the basal ganglia on CT. It is usually static but may be progressive in the most severe cases, and typically when seen in the first year of life. It's also associated with other manifestations of HIV, including a high viral load and a low CD4 count. It actually is the biggest driver of overall mortality other than PCP in the underage group, with a median survival of 22 months. Treatment, of course, is antiretroviral therapy, especially zidovudine and efavirenz if available because of their good CNS penetration, although clinically there is not a lot of data to support that. It is at least intuitively attractive in the sense that you're actually getting into the central nervous system with these drugs. So WHO has done a clinical staging schema that I'm just going to go over briefly that you can review in greater detail. But clinical stage 1 is basically an asymptomatic child or a child who has only persistent and generalized lymphadenopathy. Clinical stage 2 has less life-threatening opportunistic infections. Stage 3 and stage 4 are stages where there are more significant opportunistic infections which can be life-threatening. In the presence of any of these is an independent indication for antiretroviral therapy. Okay, so when to initiate therapy in antiretroviral therapy? The current U.S. guidelines are that all children, all adults, all adolescents should be treated with antiretroviral therapy. As of December 2018, this is also the recommendation of the WHO. I just sort of highlighted the part of the executive summary that refers to this. So how do you prioritize treatment if resources are limited? So any of those stage 3 or 4 clinical conditions, age less than 2 years, especially less than 1 year, age 2 to 5 with a CD4 count of less than 750, or a percentage of less than 25, or at age greater than 5 years with a CD4 count of less than 350. And again, this is if you are in some way prioritizing which patients are to be treated. Another very, very rough way of deciding if a patient warrants treatment is by looking at the total lymphocyte count. Again, it's a very rough estimation, but any total lymphocyte count of less than 1,200, especially if it's persistent on more than one measurement in a patient with HIV, suggests a CD4 count of less than 300 and a percentage of less than 25. So if that is the only test you have and you are needing to prioritize which patients should be treated and which patients you may potentially defer treatment on, you can look at the total lymphocyte count. Obviously, we would prefer that we use CD4 counts and percentages for viral load testing. The risk of disease progression is overall lower for older children than for infants. The optimal time to initiate the therapy in terms of data is still a little bit unknown, but again, we recommend that all treatment, all people with HIV be treated because data suggests immune response to ART is better when treatment is initiated at higher CD4 percentages or counts. And now I think I'm going to turn the slides over to Dr. Sabina Holland, who will talk about current antiretroviral therapy medications and treatment choices. Thank you very much.
Hello, my name is Sabina Holland. You can see on the slide now that this is a list of the current antiretroviral medications that we have available and that are FDA approved for pediatric treatment. And what I've done is superimposed those or looked at what may be available to you shortly. And then we have the list of the available antiretroviral therapies here. And so if you look at this slide, what we see is that in all of the categories, you have abacavir, lamivudine, tenofovir, and zidovudine for choices in the NRTI category. Efavirenz and nevirapine are your NNRTIs, and atazanavir is your choice for a PI. In terms of choosing an initial regimen to treat pediatric patients that are living with HIV, your goal of therapy is to reduce the HIV viral load to below the limits of quantitation or detection on very ultra-sensitive assays, and then to also preserve or normalize the immune status. In terms of what medications you should choose, you want to have a combination regimen that has at least 3 medications. The first is a dual nucleotide reverse transcriptase inhibitor. That will serve as your backbone. You will choose 2 from that category, plus 1 of the following: an integrated strand transfer inhibitor, a non-nucleoside reverse transcriptase inhibitor, or a boosted protease inhibitor. When thinking about the medications that are currently available to you, your choices are to use 1 in NRTI in addition to your 2 NRTI backbone, as well, or a PI-based regimen, which would be atazanavir plus 2 NRTIs. Thinking about the choice between an NNRTI-based regimen versus a PI-based regimen, there are certain advantages or disadvantages to either group. Regarding NNRTIs, your advantages are going to be that you have less dyslipidemia and less fat maldistribution compared with a protease inhibitor-based regimen. You're also sparing your PIs, and you may have a lower pill burden. The disadvantage is that resistance can develop very easily. It can happen, for instance, with a single mutation. You also run the risk of having resistance already develop, especially if the infant received nevirapine as part of prevention to mother-to-child transmission. And there is cross-resistance between efavirenz and nevirapine. This category of medications also has the potential to have multiple drug interactions. When thinking about PI-based regimens, the advantages are that the efficacy in the pediatric population is very well documented. Resistance requires multiple mutations. The disadvantage, however, is that there can be a lot of metabolic complications. You still can have drug interactions, have a higher pill burden, and you can have a poor palatability of your liquid formulations, especially with Kaletra, that can lead to decreased adherence in this age group. When thinking about preferred regimens for children, as I mentioned, you want to choose 2 NRTIs, and then I've listed it by age here. So if the child or infant is less than 14 days of age, you want to choose nevirapine. If you have it available and they are greater than 2 kilograms, you want to use or choose raltegravir. Greater than 14 days, less than 3 years, you can use Kaletra, which is lopinavir boosted with ritonavir or raltegravir. And if you have a child that is greater than 3 years but less than 25 kilos, you can choose atazanavir boosted with ritonavir, darunavir boosted with ritonavir, or raltegravir. If the child is 3 and greater than 25 kilos, you can choose dolutegravir or elvitegravir boosted with cobicistat. That's only available as a fixed dose combination drug, however. This is a table that just demonstrates what previously said. In terms of the alternative regimens, you can see that the choice to use 2 NRTIs plus nevirapine or plus atazanavir continues until from 14 days until less than 3 years of age. The remainder, as I've mentioned before. When thinking about what to choose in terms of your NRTI backbone, the recommendation for all children less than 3 months of age is zidovudine plus imivudine or emtricitabine. Once they're 3 months to 6 years of age, you want to choose either abacavir or zidovudine plus either limivudine or emtricitabine. And as children begin to age and are greater than 6 into early adolescence, the recommendation is to choose abacavir plus limivudine or emtricitabine. As they approach 25 kilos, and if they're receiving an integrase inhibitor, then you can begin to start thinking about using tenofovir. Alternatively, you can choose zidovudine plus abacavir for children ages 3 months and older. 2 to 12 years is when you can start thinking about using tenofovir plus limivudine or emtricitabine, or zidovudine plus 3-TC or FTP. So in terms of pediatric antiretroviral use, one of the most challenging issues that we experience here is adherence. And so you want to monitor adherence and inquire with both the child as well as with their guardian or whoever is responsible for administering their medication at each visit. And what I like to do is ask them how many times they have missed their medication in the last 3 days, in the last week, and since their last visit. Another thing that is important in pediatric-based medicine is that as they gain weight and as they age, you can have certain changes in their metabolism, and so we monitor their dosing rather frequently until they reach the sexual maturity and age to where they can be started on an adult dosing regimen. The last thing that you want to make sure that you always include is monitoring for toxicity as well as keeping up with their immunizations. In the long term, considerations include the potential for virologic failure, immunologic failure, and whether or not you have the capability of doing resistance testing. In terms of thinking about treatment interruption, it's something that we don't do frequently. However, in the setting of having a patient, a pediatric patient, and a guardian who do not take their medication or take it very intermittently, we would rather have them not expose their virus to that medication and risk the development of resistance. And so until we can figure out or determine exactly what's causing them to have difficulty taking their medication, we will do a treatment interruption. In terms of adherence, the optimal suppression of the HIV virus requires more than 95% adherence. Anything less than about 90% 70 to 90% is associated with the development of resistance. And we know that you can improve adherence by decreasing the number of pills that the child is responsible for taking and simplifying the dosing, so having them take it at morning and nighttime rather than having them take it every 12 hours, by offering them support and then congratulating them on a job well done, and also reinforcing the importance of medication adherence by inquiring about it at each visit, by continuing to provide education to the guardian as well as to the patient about the importance of taking their medication, and developing a trusting relationship. One thing that we know is the more treatment experienced the patient is, the less likely that their subsequent regimens will be effective. And so your best chance at success with treatment of pediatric patients is with your very first regimen. Thinking about testing or monitoring their response to antiretroviral therapy, there are a few things that we recommend in terms of thinking about a regimen that includes nevirapine. We're recommending checking liver function testing if available at initiation of therapy, at 2 weeks, at 1 month, and then every 6 months if there are no abnormalities. If a child is started on a zidovudine-based regimen, we recommend checking a complete blood count at baseline or at initiation after 2 weeks, and then after a month and 6 months if everything looks well. If you have the capability, checking a viral load and CD4 count every 3 to 6 months when they're on therapy is recommended. After they've been stable and adherent to their medications, they can space out their CD4 count testing to every 12 months. If they aren't started on antiretroviral therapy, we recommend checking the viral load and CD4 count every 3 months. This I've included just as a sort of summary of everything we talked about in terms of the things to evaluate at each visit, including the adherence, their lab values, as well as any screening testing that they may need. I'm just going to skip a lot of these slides that we included so you'll have them. So I'm just going to briefly talk about different classes of regimens. In terms of thinking about your integrase inhibitors, the advantages of using this class of medications is that they have few drug-drug interactions. They're very well tolerated. We try to, if available, we try to actually prescribe integrase inhibitors to the majority of our patients unless they have concerns about adherence. There is difficulty in terms of dosing and safety, with raltegravir being the integrase inhibitor that has the most data. In terms of your NNRTI, as I mentioned, there's the lower risk of dyslipidemia and fat mouth distribution. There's a lower pill burden leading to increased adherence, but the downside is that a single mutation confers resistance. And so we choose this category of medication for those children that are younger, especially if we don't have the capability of prescribing Kaletra or lopinavir or ritonavir. But any concerns about adherence, we move to the PI-based regimen because they are very, well studied and their efficacy is well documented, and because the resistance requires multiple mutations to develop.
Okay, thank you very much, Dr. Anand. So now I will introduce our third speaker, Dr. Susan Koyovan, and after her presentation, we will start question and answers. Can I do it? Okay, we can close. Okay, we can close. So our third presenter is Dr. Susan Kayovan. She is a professor of OBGYN and medicine at the Brown University School of Medicine and School of Public Health. She is the director of the Brown Global Health Initiative and the director of the Providence Boston Center for AIDS Research. Dr. Kayovan has served in many key leadership positions in past. She has been the principal investigator and co-investigator on many NIH and CDC grants since 1996. She is a member of 3 HIV guideline committees, the Public Health Service Task Force, Perinatal Antiretroviral Guidelines Working Group, chairs the HPV Working Group, USPHS IDSA Guidelines for the prevention and treatment of opportunistic infections, and the HIV Adult and Adolescent Treatment Guidelines, and the CDC STD Guidelines Committee. She is a member of the NIH Advisory Committee on HIV-related research in women and girls. She has been member of several NIH review committees. She works primarily in USA, Kenya, Philippines, and Bangladesh, but collaborates with many other countries as director of the Brown Global Health Initiatives. So Dr. Kayovan, please. Give me 1 minute, I just need to open our slides, yeah. So you go back to, you can close this door.
Thank you, Fisa, and thank you for inviting me to be part of this presentation today. And I am going to talk about the prevention of HIV mother-to-child transmission. I first want to talk about the timing of when a baby can get HIV from her mother. In formula-fed infant populations where no breastfeeding is done, the baby can get HIV from the mother at the early part of pregnancy or later part of pregnancy, which we call the antenatal period. And that covers about 25 to 35% of HIV infections in children. However, the bigger portion of how the baby will get HIV and when is during labor and delivery, and that comprises about 65 to 75%. So the overall cumulative risk of perinatal HIV transmission without any antiretroviral therapy is about 20 to 25%. But the proportion of when the babies get infected is mainly during labor and delivery. However, if you have a breastfeeding population, HIV can be transmitted from the mother to the baby through breastfeeding. And it's not a small amount. The longer the period of breastfeeding, the higher the chances of giving HIV to your mother, to the baby from the mother without any antiretroviral therapy. And that can range as high as 40 to 45%. So you might save your baby from being infected during pregnancy, during labor and delivery. But if you breastfeed without any antiretroviral therapy, the mother can infect the baby up to 40 to 45%. So what would make a mother give HIV to her child? Because as you could see, even without any antiretroviral therapy, not every mother who has HIV gives it to her baby. Only about 20 to 25%. It's not 100% all the time. And I think that's very important to understand. When a mother asks you, what are the chances of me giving HIV to my baby? if I don't take any medications? The answer is 25 babies out of 100 babies. Why some babies are protected and others are not protected, we don't fully understand. But women who have advanced HIV or AIDS, women who are not on antiretroviral therapy with high amounts of HIV in their blood, in their genital tract, in their breast milk, women who have a lot of malnutrition or nutrient deficiency, women who have a premature rupture of the membranes, women who have invasive procedures during delivery, women who have infections like chorioamnionitis will increase the chances of a mother giving HIV to the baby. When a baby is premature, that baby is also at higher risk of getting HIV. And as we discussed before, the longer the mother breastfeeds without any antiretroviral therapy, the more likely the baby is going to be infected. So what we would like is to decrease all these risk factors so that we can decrease the chances of a mother giving HIV to their baby. So what are the pillars and strategies to prevent mother-to-child HIV transmission? We always talk about antiretroviral therapy, but that is not the only important pillar. To really decrease mother-to-child transmission, we really have to prevent HIV in young women, particularly reproductive age women. We have to test women who are sexually active. We have to test all pregnant women, because if we don't know their HIV status, then we cannot intervene. A woman is better to be on antiretroviral therapy with controlled plasma viral load before she gets pregnant. Remember that pregnancy is different from just any other time during HIV transmission. Most women do a pregnancy test or know that they are pregnant not in the first trimester. Women usually wait for a missed period and then probably another month for a missed period before they begin to suspect that they are pregnant. If a normal pregnancy is 9 months, that leaves us only 7 months to protect that mother and that baby. So it is very, very important to test women at risk for HIV before they get pregnant. And as much as possible, all pregnant women, the earlier the HIV testing is done, the better. The other thing is to prevent unintended pregnancies in all women, but particularly HIV-infected women. Preconception counseling is very, very important. HIV-infected women, it is safe for them to get pregnant, and it's safe for them to have babies, and their babies will be safe from HIV if they get good care. But if they're not ready to get pregnant, contraception is a very, very important part of preventing mother-to-child transmission. Then we talk about antiretroviral therapy. That's when it comes in, because that's when we can really prevent mother-to-child transmission. But we should not forget support for HIV-infected mothers and their families. Dr. Larkin and Dr. Holland talked to you about adherence to therapy, and family support and understanding of HIV and mother-to-child transmission is very, very important, particularly for families in Asia or South Asia. We are culturally adapted to having big families. We have our own family. We get married. We get a whole family of in-laws, new cousins, second-degree cousins, all aunties and uncles and grandparents. Everybody is in your business. If HIV is stigmatized, nobody will want to get tested for HIV. And particularly, nobody wants the stigma from the family members, from the neighborhood, from the communities. And if you're hiding from HIV, you're hiding going to the doctor. You don't want to be tested. If you see a doctor, you're hiding your medications. You don't want anybody to see that you're taking medicines against HIV. And you know what? Even if you could afford it, even if you could afford formula feeding, you will breastfeed because that's normal in your community. Because anybody who doesn't breastfeed might be suspected of having HIV. So I think we always concentrate on antiretroviral therapy, but we have to look at all these other strategies to really have a successful prevention of mother-to-child of HIV. So how are we doing in eliminating mother-to-child transmission in the world? Have we improved in covering pregnant women in receiving antiretroviral therapy to prevent mother-to-child transmission? I would say yes. If you look at this figure, we have been improving. Overall, globally, we are over 75% in covering women who are HIV infected and who are pregnant. But that only presupposes we know that they have HIV and we diagnose them during pregnancy. Nevertheless, that's a lot better than before 2010 when many pregnant HIV-infected mothers did not get any treatment at all. The second figure will show you the coverage of pregnant women who received ART by region. And these are only estimates. If you look at where we are in the Asia and Pacific, we're at about 56%. In the Caribbean, it's a lot better. In East and Southern Africa, where we have the most number of pregnant women who are HIV infected, in some regions, it's as high as 93%. So that's very good numbers. But Eastern Europe and Central Asia, there are no reports. They don't report their figures to the WHO. Latin America is also doing very well at 73%. Middle East and North Africa, not good at 22%. West and Central Africa, not very good at 48%. In the United States, I must tell you that if a woman is being taken care of in a big hospital, the coverage in our region, in our hospital, is 100%. But that is only presupposing we know that you're HIV infected. In our hospital, we offer HIV testing to all pregnant women, regardless of risk factor. Sex is a risk factor. The fact that you're pregnant means you have unprotected sex. You don't need any other risk factor than that. So the HIV testing rules are also very, very important in how much testing we can do. Many years ago, the rule in Rhode Island was if you want to do HIV testing, it was called an opt-in testing. You needed 20 minutes of pre-test counseling, then you undergo a consent form and you sign that you wanted to be HIV tested, and then when your results come back, you needed another 15 minutes of post-test counseling. That was impossible to do. When that was the law, our testing rate for pregnant women was 58%. Then doctors fought for change in legislation, led by now our director of the Department of Health in Rhode Island, and Dr. Brian Alverson. They went to talk to the lawmakers and said, this is not good. We're having a lot of HIV-infected babies. And they changed the law to what we call opt-out. It means that HIV testing is part of a routine prenatal care unless you say no. And instead of 20 minutes pre-test counseling, we can give you a brochure in any language with the literacy level of a 5th grade reader. And if you are not literate, then we will have a person talk to you about the testing. By changing that legislation, our testing rate in pregnant women is 99.8%. So your legislations and your rules about HIV testing is a very, very big part of preventing mother-to-child transmission. Can we eliminate mother-to-child transmission? Yes. If you look at this figure, every year we are preventing many babies from getting HIV. Millions of babies do not get HIV because we have implemented HIV testing and antiretroviral therapy in pregnant women. As late as 2002, we have 400,000 babies being infected worldwide. But with better testing and antiretroviral therapy in 2017, we have less than 200,000 babies. That's like a 50% reduction. In Western Europe and in the United States, mother-to-child transmission of HIV is less than 1%. In the United States, in the last few years, there are less than 200 babies who are HIV infected. Why? Because mothers don't come in for prenatal care. Mothers didn't know that they were HIV infected. And mothers who refuse to take their antiretroviral okay. So, what is the best thing to do to prevent mother-to-child transmission? Combination antiretroviral therapy. If you do this, even in some African countries, mother-to-child transmission is 1% or below. So it's not only the rich countries that can do it, and the WHO now proposes what they call option B. All pregnant women, regardless of CD4 count, regardless of viral load, should be on antiretroviral therapy and should be lifelong. While they are pregnant, during labor and delivery, while they are breastfeeding, and even after they are breastfeeding. So how does antiretroviral therapy reduce mother-to-child transmission? By lowering maternal blood and genital tract viral load. So you want to achieve a below detectable viral load. Then the other point is pre-exposure prophylaxis to the infant. So before the infant is born, the mother is already on antiretroviral therapy. And after the infant is born, the mother is still on antiretroviral therapy. Like Dr. Holland said, that not all HIV medications are safe for pregnant women. So what are the issues about giving antiretroviral therapy to pregnant women? Prematurity. There are some medications that lead to prematurity. Not all countries do have this, but particularly in Africa, there is a link between some antiretroviral therapies and prematurity. There are also medications that might cause congenital anomalies, and some that might cause fetal bone problems in the children. That will cause anemia, like zidovudine. Some might cause mitochondrial dysfunction. In the long run, do exposing babies and infants and children to antiretroviral therapy increase malignancy risk? We don't know. Neurodevelopmental problems, cardiovascular anomalies? We don't know. But whatever these problems outweigh the life situation and the mortality and morbidity of babies getting HIV. We know we have these problems, but a baby who gets HIV has to contend with more problems than any of these that may or may not happen. So let's make treatment for mothers who have HIV who are pregnant simple. The WHO says the dolutegravir-based regimen is recommended as the preferred first-line treatment for any person living with HIV. However, in women and adolescent girls with childbearing potential, dolutegravir should only be given for those with contraception and those who are not planning to get pregnant, because dolutegravir has been associated with an increase in neural tube defects. When I look at the medications that are available in Pakistan, you have efavirenz, you have raltegravir, and you have protease inhibitors. So let's make it simple. For all of you who are taking care of HIV-infected pregnant women, think of efavirenz plus emtricitabine or lamivudine plus tenofovir. If they don't have any resistance to first-line therapy, think just one kind of treatment. That will make your life very, very easy. If you have access to raltegravir, you can change the efavirenz to raltegravir. But don't make it complicated. If efavirenz is your first line, then use efavirenz. If you happen to have dolutegravir, you can use it after the first trimester. Now, your second-line treatment are protease inhibitors. So, as previously discussed, in NRTIs like efavirenz, one of the big problems is the development of resistance. If you have resistance in an HIV pregnant woman, then use your protease inhibitors. But overall, if you want to simplify your life, just think efavirenz, emtricitabine, lamivudine plus tenofovir. That's all. How do we care for women who are pregnant? We have a problem because in many resource-limited countries, many of our patients don't get prenatal, or they deliver at home and they don't come to clinics. We're lucky if they come to community health centers or district hospitals or referral hospitals. You will have to try and solve that. You will have to find a way of reaching all women, whether they're in the urban areas or in the rural areas. I know that Pakistan has a big array of midwives, nurses. Believe me, in Asia, manpower is not our problem. We have many, many educated people, unemployed, underemployed, too smart for the jobs that they are doing. If we really wanted to do HIV testing in the rural areas, we can deploy our midwives, our nurses, our medical staff to learn to be certified to do HIV testing, and we can do it. We can also teach our nurses to provide antiretroviral therapy to check for adherence. And we can let the midwives deliver the babies. They don't have to come to hospitals to be successful in preventing mother-to-child transmission. That is the ideal scenario. That's the goal, but it's not an excuse not to have a program to prevent mother-to-child transmission in resource-limited areas. I hear that so often. I go all over the world, and they tell me it can't be done. 70% of the women deliver at home. How are we going to reach them? You can reach them. Somebody is delivering their babies. Somebody is helping them, whether it's a midwife, a paramedical staff, whoever it is in the community, we can teach them. This is not very difficult. We just have to have the will to do it. So your antenatal care is no different for an HIV-infected pregnant woman than any other one. You need to do a CBC to know that they're not anemic. You need to do an STD workup to know that aside from HIV, they don't have other sexually transmitted diseases that could be given to their babies. And you have to check, because we are going to use tenofovir, we have to check their kidney function. And Asia is endemic for hepatitis B and also hepatitis A. Hepatitis C, a big problem too, but there's no treatment for hepatitis C right now in Asia, and we don't treat pregnant women for hepatitis C during pregnancy. So if you have the capability, please test for hepatitis A, B, and C, and give immunizations to protect those mothers, okay? And then prenatal vitamins, very, very important. And also folic acid supplements. We do not give folic acid supplements to our pregnant women. We also do not test for parasites. Pregnant women already are disadvantaged in terms of their hemoglobin and hematocrit. If they have parasites, they will be more anemic. So it's easy to treat parasites. We are better than in the US treating parasites because we know the parasites. Here, when we see ascaris, oh my God, it's ground rounds. When we see tapeworm, it's more than ground rounds. It's reportable in journals. It's everyday occurrences to all of us in Asia. So please, diagnose for parasites and treat all these pregnant women for parasites, okay? And then start antiretroviral therapy the soonest possible. If you can do it, please do a baseline CD4 count and a plasma viral load before you start antiretroviral therapy. You do not have to wait for the results. You just have to do it. Then start your antiretroviral therapy. Why? So that you will know if your antiretroviral therapy is working or not. Remember, most pregnant women, we only have 7 months. We're talking about a very, very short period. After you start antiretroviral therapy, if at all possible, please repeat a viral load in 2 to 3 months, because then you have to see a decrease in your viral load. If there's no decrease in your viral load, you have a problem. Change your medication. It's not working. Genotyping, I was told, was not consistently available. If it's available, do it before you start antiretroviral therapy. Do not wait for the result. You can change your antiretrovirals after the results come in. If there's another time after the 8 weeks of starting antiretroviral therapy to do another HIV viral load, it's at 32 weeks or a bit later. You know why? Because if the viral load is still over 1,000, you should offer the woman a C-section if it is at all possible. At 38 weeks, do not wait for them to go into labor, because then you'll be dealing with an emergency. That is the reason for the plasma viral load at 32 weeks. And again, breastfeeding. In the US, the guideline says no breastfeeding at all. But everywhere else in the world, especially in resource-limited areas, breastfeeding is the best, even for a mother who has HIV. If the mother has HIV and takes antiretroviral medications, the chances of her giving HIV to her baby, even while breastfeeding, is very low. You stop breastfeeding, you give diluted formula, unsafe, unsterile water, the baby develops diarrhea, malnutrition. These babies are going to die from malnutrition and diarrhea and pneumonia. They're not going to die from HIV. So please, encourage breastfeeding in resource-limited areas unless you have very, very good access to good formula feeding. How long should you breastfeed? We prefer only mother's milk for 6 months. After 6 months, you can do mixed feeding. But you can go on breastfeeding until 12 to 24 months, depending on your resources and how healthy the mother and the baby is. But all that time, be adherent to antiretroviral therapy. I was going to bring out the dolutegravir problem and neural tube defects. A study in Botswana showed that patients who were taking dolutegravir before they got pregnant had a risk of giving neural tube defect to their baby at about 1%. Then that was modified to 0.6%. But in your case, you don't have dolutegravir, so don't even worry about it, okay? Worry about it when dolutegravir becomes available. So what are our takeaway messages? We need to test all women who are sexually active. We want to decrease unplanned pregnancies. We want to put all pregnant women on antiretroviral therapy lifelong, particularly those who want to breastfeed. We can eliminate HIV transmission from mothers to infants. It can be done, and it's one of the biggest successes for HIV treatment. We have no vaccine. We have no cure. But our biggest success all over the world is decreasing mother-to-child transmission to 1% or lower all over the world, and it can be achieved. Then, watch out your women, treat them, reach them in the rural areas, be available, and don't forget family support, community support, and an empathetic doctor. Most important thing is a doctor who does not do any judgment, who is not arrogant, overbearing, and I'm the doctor, I say this, and you do this my way or no way. You lose your patients that way, you drive them away. We have a big responsibility as doctors to keep our patients, treat them well, and make them healthy. Thank you. Great.
Great, everyone. Now we will start taking the questions, but we will do the questions from the window first. So let's see how many questions we have in window. Okay, so it doesn't look like we have any. I think that we have some technical problem today. And so Dr. Aziz Sumro, can you please introduce the groups and start taking the questions from them?
Sure. And who is this Dr. Sumro? I'm here from New York. I belong to the area where there's a recent outbreak in Larkana, which is the town of former Prime Minister of Pakistan, Benazir Bhutto. And I will give a chance to people who are sitting in the Benazir Bhutto Medical University. I will introduce the Dr. Farooq Sumro, who has been focal person for HIV since 1992, and a former Vice Chancellor, Dr. Murtaza, and a head of Department of Radiology, Dr. Farooq Sheikh. Go ahead, please.
I'm a pediatrician, Dr. Shantidal from SMBBU Larkana. Thank you very much for updating us regarding the management of HIV in children. I am just giving you the current clinical scenario. We have more than 350 cases from 2 years to 5 years of age with HIV, and they are mostly wastage, failure to thrive, diarrhea, chest infection, and oral thrush. So they are coming in stage 3 and onward. And we are testing them and starting treatment of antiviral drugs, 3 drugs combinations. Now what we are facing problem currently, they are producing, the baby who's on drugs are producing vomiting, the few are developing skin rashes. So should we stop these drugs for temporary, or to what things we should to monitor when the baby is on this antiviral drugs?
So, this is Dr. Jerry Larkin. In terms of, so what is the primary regimen you're starting? Is it lamivudine and efavirenz?
Dr. Jamro in Benazir Bhutto Medical University, go ahead, please. Respond to the question. Hello.
Repeat again. Hello.
I'm sorry. So what is the primary antiretroviral regimen you're using?
We are using limivudine, nevaparin, and zidovudine. These are the 3 antiviral drugs which we are giving to our children.
So there are 2 issues with nevirapine in particular that you may need to be aware of. So nevirapine has a tendency to cause rash. Oftentimes it can be avoided by using a lead-in dosing regimen, and oftentimes if the rash is not severe, so there's not desquamative lesions, there is not ulceration of the mucosal surfaces, you can treat through that rash, giving them Benadryl, steroid creams, emollients of other sorts. So, relatively unremarkable rash in nevirapine will usually resolve on its own. Yeah. The lead-in rash. Yeah, so in children, it would usually, so nevirapine is typically a twice a day drug, and the way it is usually given at initiation is actually just giving it once a day, because it has a very long half-life, and it will hang around enough that you can dose it daily for the first 2 weeks, and then you increase to the twice a day regimen. So that may be part of your issue with rash. The issue with vomiting is potentially a little bit more concerning because at high CD4 counts, and again, you'd have to know what the CD4 count is, you potentially can cause problems with liver. So the thing I would look for is whether or not their LFTs are elevated, if you can test for that, or if they are developing jaundice or other signs or symptoms of liver involvement. If the child if the symptoms do not resolve, or if you have evidence that there is some issue going on, your best plan of action would be to stop the antiretrovirals and try a different regimen that does not use nevirapine. You can probably still use the zidovudine and the lamivudine, but you would want to substitute it either with atazanavir, if that is one of the other primary drugs available to you, or efavirenz. That is the other drug that is available to you. So that would primarily be to just go back again. Rash on exposure to nevirapine will oftentimes resolve if you use a lead-in dose of once daily for the first 2 weeks and then increase to twice a day. And the thing I would be concerned about a lot of nausea and vomiting is if their liver function tests are abnormal, you would want to try and substitute the regimen to one that is efavirenz based or atazanavir based rather than nevirapine based. Hope that's helpful. If children have a lot of esophageal candidiasis, so one of the issues sometimes is that if you have an opportunistic infection, such as candidiasis or PCP pneumonia or some other illness, it's oftentimes difficult to understand when a patient starts antiretroviral therapy in that setting, whether or not they're still exhibiting or still experiencing symptoms related to the opportunistic infection. Early treatment of with antiretrovirals is critically important in any patient diagnosed. However, it is best to do that in the setting of a clinically stable patient who is feeling well. So you may need to take the approach of treating the esophagitis, treating the pneumonia or other symptoms or other illnesses before actually going in with the antiretroviral therapy. That would be the other possibility that you might be experiencing. Hope that's helpful.
Next, thank you, Dr. Jerome. I will give a chance to Kharagpur Medical College if they have any question. Kharagpur Medical College, please.
Can I ask you a second question from SMBB Larkana?
Sure, go ahead.
Currently, we have 110 pregnant mothers who are HIV positive on antiretroviral treatment, and newborn are getting prophylactic, that is nevapirin. Once they born, we are treating prophylactically starting treatment. How to monitor these newborn babies, and how long we should continue this antiviral drugs to the newborn babies? Prophylactic.
Are you using nevirapine or zidovudine or zidovudine nevirapine?
Nevapirin.
Just nevirapine alone?
Yes, alone.
So typically the dose is just one single dose of nevirapine immediately after delivery to the baby.
Me, Dr. Bhutra,
This
Oxygen Gynae Department, Unit 2, Kharagpur Medical College. Sir, I want to ask that you mentioned the viral load about the 1,000 colonies, but you mentioned that did not mention the CD4 count to start the monotherapy or the regime that you have mentioned in this presentation. Kindly elaborate this session.
So you only do in resource-limited countries where money is a problem. I would suggest a baseline CD4 count and a viral load. The reason for the CD4 count is to see if it's below 200, because then the mother will need prophylaxis for opportunistic infections like for a PJP pneumonia, which they will need Bactrim. But regardless of any CD4 count, any viral load, all pregnant women should be started on antiretroviral therapy. So if you have a good CD4 count the first time, don't waste your money. Use your money for a viral load, because that is more important.
We have to have the woman to have a below detectable viral load the most amount of time during pregnancy. If you get a CD4 count above 200 and the mother's on antiretroviral therapy, don't bother wasting your money on another CD4 count. Save your money for your viral loads.
Okay. Thank you, Mrs. It is Fiza Gilani here. Please wait for the question and then wait for the answer to that question and then please ask your question. Thank you very much. So Dr. Sommer, you can go.
Yeah, so this is Jerry Larkin again. I wanted to follow up on the issue of treatment of the newborn infant to a mother who has HIV. So as Dr. Kuubin said, of course, the most important thing prenatally is for the mother to be on fully active antiretroviral therapy. In certain national guidelines, single dose nevirapine to the child is very effective in decreasing the risk to the infant further. However, the best approach in terms of antiretroviral therapy for the newborn infant is zidovudine for a total of 6 weeks postnatally. If you're in a situation where the mother has had no antiretroviral therapy prior to delivery, she should be placed on AZT as soon as she has been brought into medical care during labor and delivery, and also receive nevirapine. Different national guidelines have different approaches to this issue based on their resources. But AZT is probably is the best drug to administer to a newborn infant born to a mother who is HIV positive. The other important thing to understand about treatment of newborn infants born to mothers with HIV is that at 6 to 8 weeks, they should actually start trimethoprim, sulfamethoxazole prophylaxis for PCP until it has been established that they are HIV uninfected. And the only way to do that is either through viral load testing if the child is no longer on antiretroviral therapy, or ultimately by demonstrating seroreversion, meaning that their HIV test goes to negative somewhere between 12 and 18 months of age. So just to reiterate that, the treatment of a newborn infant born to a mother with HIV optimally is AZT for 6 weeks. At 6 weeks, they begin prophylaxis with trimethoprim sulfamethoxazole, and then ultimately should be demonstrated to be HIV negative, either through viral load testing if that is available, or through antibody testing sometime after the age of 12 months. But I would also look to your national guidelines, which generally do address this, or to the guidelines at the AIDSinfo.gov website.
Thank you, Dr. Jerome. Does Kharagpur Medical College has any question?
Yes, I am Dr. Farooq Mamro, Assistant Professor, Community Medicine, Kharagpur Medical College. I have one question, sir. What medical superintendent and health ministry and concerned departments, head of department can do preventive measures to stop transmission from mother to child? What is the role of health ministry, medical superintendents, and their internal staff to stop this transmission?
I would assume that your Ministry of Health has guidelines to prevent mother-to-child transmission. Most of it probably is based on WHO guidelines. And I would think that you should talk to the people at the Department of Health. We have helped many countries develop their mother-to-child or perinatal transmission guidelines. So, but I would be very surprised if Pakistan doesn't have one. I'm sure they do.
So this is Dr. Rizwan Naeem. Let me answer to that question. So what we know is that CDC and WHO team is in Pakistan and working on to see what the root cause analysis is, and doing a root cause analysis basically. So putting this question, the information this group provides is for everyone, all healthcare providers. So pointing out exactly who can do what is very difficult for us. What we can say is this, that look for if government of Pakistan or government of Sindh has guidelines how to prevent mother-to-child transmission. If not, this team is willing and happy to work with them and develop those guidelines. Thank you.
Thank you, Dr. Rizwan. Now I will give a chance to Gumbert Institute of Medical Sciences if they have any question. Go ahead.
Can I share you the model which we are following, that mothers who are suffering from HIV in SMBB Larkana?
Go ahead, please.
We have a focal person who is just looking after the mother who are pregnant and suffering from HIV. They are registered and they are screened for mother who are coming for antenatal care. And up till now, we have 110 cases of HIV positive pregnant mothers. And we are providing antiretroviral drugs to the mothers and advising them the aseptic technique of delivery of the newborn baby. And once the baby born, we are putting on prophylactic treatment for 6 weeks and follow these newborn babies.
Yes, that is exactly what you should be doing. We agree with what you're doing.
Hi, do you have any follow-up question at the Gumbert Institute of Medical Sciences?
Yes, my name is Dr. Shafi Muhammad Hassan. I work in the Gumbert Medical Institute as Assistant Professor Community Medicine Department. My question is, how much a dose given an infant baby?
What should be are the dose guidelines, or what dose for infants and children or pregnant women?
Yeah, for pregnant women, it's the adult dosing. For the infant and children, is this for the Dovidine prophylaxis?
Yes, for prophylaxis.
It's 4 milligrams per kilogram per dose, twice a day.
Thank you.
Is 7 is online? Medical Center from 7, are they online? We have a Dean of Faculty in Sindh Medical University, Dr. Afridi. Are you online? Do you have any question, Dr. Afridi? He's a professor of psychiatry. Maybe he has any question about psychological aspects of the treatment. Dr. Afridi. I see Dr. Aisha online. Dr. Aisha, do you have any questions?
Assalamu alaikum. Thank you very much for the opportunity. My question is for the last speaker, who is expert in OBGYN. So what is the best mode of delivery a baby whose mother has HIV? And what are recommendations for elective cesarean section? So I need guidance on that. Thank you.
It depends on the plasma viral load. If the plasma viral load is less than 1,000, all the women should be delivered vaginally except for obstetric reasons. If the plasma viral load is over 1,000 at 32 weeks, when you repeat your viral load, or late in the 3rd trimester, those women should be offered C-section.
Thank you.
Thank you, Dr. Susan and Salamat. Dr. Lagari, do you have any question? Dr. Lagari, please. Dr. Palmer from Canada, do you have any question?
So Aziz, thank you very much. Actually, I'm not teaching a pediatric group, so I don't have any particular question, but I would like to comment on the discussion. Actually, Dr. Suzanne commented that the lady who got HIV, mostly she had experience of unprotected sex, but unfortunately in Larkana, this is not the reality. In Larkana, the cause is mostly the blood and the syringes. We use syringes, and mostly the children. I think our colleagues are agree with me that our children, mostly those infants, their mothers are non-HIV. So they got either blood or blood-stained syringes of reuse. So the causes of our transmission mode in the northern here in North America is different than the transmission mode of HIV in our population in Larkana and Sindh and Pakistan. So we need to look into that. Otherwise, I'm very happy that I'm in the group, and I'm thankful to all the speakers. It's a wonderful session. Thank you very much.
Thank you, Dr. Palmer. Dr. Ibrahim, do you have any question?
Dr. Somru, before that, I want to ask the question. There was a question last week which we didn't know the answer, and I think that question was asked by the same doctor from Canada, and he asked that how long a viral HIV virus can survive in a tube, and we all, our group at Brown, in a stranger tube, and we all as a group at Brown looked into the answer of this, and the answer was it can survive up to a few months. Susan, if you want to comment on this. Depending on temperature and humidity, we have several studies have found that the virus is alive up to 6 to 8 weeks in syringes. So, if you use a syringe, if you just clean it with water and not all the blood is taken away, then the virus can survive 6 to 8 weeks. The best way to clean is bleach. Bleach kills HIV. Bleach is the one that kills HIV. I wouldn't advise for using.
Yeah, just as a follow-up to that as well, I think one of the important things to also understand is that other than mother-to-child transmission, sexual contact, and blood transfusions or contaminated medical devices, HIV is not a very robust virus. So it does not live easily out in the environment or even on human skin or saliva. It really has to be sort of a blood or sexual transmission of some sort. And that's an important thing to make sure that families understand and patients understand as well. So yes, syringes, as you've experienced, can be a very potent mechanism to drive an epidemic or to cause infection. But out in the environment, in the soil, on environmental surfaces in a household, HIV does not survive very well, and it is generally easily killed by things like bleach or even just soap and water, ultraviolet light and just sunlight destroys the virus relatively easily.
I think that that's very important to understand that hepatitis B and hepatitis C are much easier to transmit than HIV. Nonetheless, there's an HIV epidemic, so we know it's being transmitted. I think that the syringe problem that we have is very much reminiscent of early HIV in many resource-limited countries. I remember India had that problem too with reusable syringes. That being said, I think that we shouldn't scare the public and the families. You can hug a person with HIV, you can kiss a person with HIV, you can use the same plates, the same spoons. They don't have to have different utensils or different beds, bed sheets and everything in the household. They can share everything in the household. The biggest issue is blood and blood exposure. I think that's what we have to worry about. But like I said, if you see blood, if there's no split, if there's a cut, then just pour bleach on it and it's non-infectious.
I will give a last chance to Benazir Bhutto Medical University. Does anyone has any question? Hello? Dr. Farooq?
Hello?
Dr. Farooq, do you have any question?
What are the early radiological changes in X-ray chest in HIV patients?
I'm sorry, could you repeat the question again?
Dr. Farooq Ahmed Sheikh, radiologist. What are the early changes in HIV patient in X-ray chest?
On a chest X-ray?
Yes, X-ray.
Yeah, in the there's no specific, early change in a chest X-ray in someone with HIV who is otherwise not exhibiting clinical symptoms of some disease process associated with HIV. So in children in particular, the most likely diagnosis you're going to make radiographically in a child who is sick is probably PCP pneumonia, and that is typically a perihilar infiltrate, although it can be pretty variable. It can look like lots of things, but basically a fluffy kind of butterfly pattern around the heart border. The second most likely chest radiographic finding you might find maybe in someone who wasn't diagnosed, and you'd sort of see something and wonder, well, what is this? Is the reticular nodular pattern of lymphoid interstitial pneumonia. So that might be a kid who's just got a chronic cough and maybe occasional episodes of hypoxia or wheezing. And that is much more common in children than it is in adults. I'm not sure that it's really described in adults with any frequency at all. And it's still a relatively rare entity even in children. But those are the two things you might see in a kid who, again, might be even undiagnosed. So a child who comes in with this bilateral perihilar infiltrate or a reticular nodular infiltrate, when what you're really expecting is a lobar infiltrate because you think they have pneumonia, or hyperinflation because you think they have asthma. So that would be sort of what you would maybe encounter.
I think in countries endemic for TB, I think TB is always a big differential, both in adults and children. who have HIV, the risk of getting TB, contracting TB, and having tuberculosis is much higher in HIV-infected populations compared to non-infected populations.
Hello, I am Dr. Farooq Rahman Sumro from Ladkana working on HIV. So my question is the necessary the HIV positive cases are necessary to admit in hospital or not? Because here people wants to admission in the hospital, they pressurize that we need admission. So what are the criteria for the admission for HIV positive? Are the OPD service or clinic service or the ward service?
Most of our patients are seen at the outpatient clinic. Only patients with hospital need level of care are admitted. I know that many doctors are scared when they see HIV and they think they all need to be hospitalized. Even in our own emergency room, all our emergency room doctors are so worried because somebody has HIV, but they just have a respiratory viral infection, or they just have an abscess, or they have gastroenteritis. Most of the HIV care can be done outpatient. They don't need to be admitted unless they have AIDS or they have opportunistic infections, or they have surgical emergencies or trauma emergencies, or are very, very sick. Most of the patients are taken care of on an outpatient basis.
I would agree with Dr. Kuhubin, and there is no difference with children as well. That the indication for hospitalization remain the same as they would in the HIV uninfected. If there's a medical reason or a medical treatment that they can only receive in the hospital, then you admit them to the hospital. But HIV itself should not be a cause for admission.
Thank you very much.
I think that was the last question.
Hello.
Jelani, go ahead.
Hello.
Go ahead.
Hello.
Yes, go ahead. Introduce yourself, please.
I'm Dr. Shabnam from Shaheed Muhammad Benazir Bhutto Medical University, and I'm working as a professor at OBGYN. My question is that one patient who is with baby has a Down syndrome, and she's very anxious, and she's due for the coronary pillar sampling. And her HIV is positive. As Dr. Susan says, in the first trimester we haven't given her the drugs. So what we do for her? She's due for the coronary sampling at 12 to 13 weeks. So in these cases, what's the criteria for using the heart therapy in the pregnant women?
We would prefer no invasive procedures when somebody is not on antiretroviral therapy. But when somebody is on antiretroviral therapy and their plasma viral load is below detectable consistently and maintained, and you trust their adherence to medications, we have done necessary obstetrical procedures like amniocentesis, chorionic villi sampling. But if the patient is not on any antiretroviral therapy and their viral load is not below detectable, we would try to avoid any invasive procedure to prevent mother-to-child transmission.
But we don't have facilities for the free cell DNA. We have option of the CDS.
Even I don't get it. Can you repeat and speak slowly, please?
Sorry?
Dr. Shabnam, can you speak slow so they can understand the question?
Actually, we don't have a facility for the cell-free fetal DNA, and we have the only option of the CDS.
So they don't have the facility of what? They only have CDS.
The non-invasive test for detection of the Down syndrome, the non-invasive test for the detection of the Down syndrome will have only the option of the CVS or the amniocentesis, and they are the invasive procedures. So my question is that.
Yeah, you can do those when the patient is on antiretroviral therapy and her plasma viral load is below detectable. You have to make sure that before you do those procedures, your patient is on antiretroviral therapy and that her virus is controlled. If not, you risk mother-to-child transmission to the baby.
Okay, thank you. Thank you so much.
Does any center has any questions before we close for the day? Dr. Janani, I think we are all set.
Thank you very much. Yeah, all set. Thank you very much, everyone, for joining. And hopefully, if you have any other question after that, you can just write it to us, and we'll try our best to answer. And next week is all co-infections, HIV, Hep C, HIV, TB, and HIV, Hep B, and all of them. So please join us next week too. Thank you very much.
Thank you, everyone.
Thank you.
Thank you very much. Yeah.